movie. She's also a TED speaker. Dr. Vibble, I'd like to invite you to speak a few words.
Thank you so much for having me here. And is it okay to share my screen now and just give a little background information? Okay, so here we go. Hopefully you can see this. Does this look, can you all see this?
Yes, ma'am.
Okay, so I would like to just share a little bit more about why I'm doing this unusual work that I feel like I was called to do in my life. Number one is because I've sustained so many personal losses, both men that I dated in medical school, who are medical students, died by suicide, not while I was dating them, but when they were married as successful physicians, leaving, children and wives behind. So then, fast forward, I lost 3 men, as you could see in the clip, 3 men within my town, physicians, well respected, within just over a year in my small town in Oregon. And then also, I had survived a suicidal depression. So at the time, I thought I was the only one on the planet who was suicidal as a physician, but come to realize when I really kind of yank myself out of what I call trauma amnesia, suicide amnesia, if I were to really assess my life with clarity, I can see that this has been going on and has affected so many people. And I just simply wanted to know why. So that's number one. Number two, I am obsessed with physician psychology. And this is probably because both my parents are physicians. So quite honestly, to survive my childhood, I had to master physician psychology. Okay, so I developed a certain level of, let's just say, emotional hypervigilance and intuitive gifts to be able to keep myself alive and safe amid the, following my parents around as workaholics through the hospital. And then the third reason is I feel as if I was appointed by my peers to do this work. I never decided to run a suicide helpline. It's just that I started speaking about this topic. And back in 2012, if you were to Google physician suicide, I was like the only one almost on page 1 of Google, okay? Like nobody was talking about this. So quite naturally, everyone started reaching out to me wanting to have long conversations. And so I found myself at ground zero, okay? And after a certain number of people tell you that you saved their life from answering the phone, it's kind of hard to stop, especially if you're a healer. So I just found myself running a suicide helpline, okay? And I just simply wanted to find out why my friends were dying, and they were all doctors. So the second slide, I think, is very significant because this is the raw qualitative data that I've collected over 10 years. This is 1,710 doctor suicides that were submitted to me organically by family, friends, and colleagues of the deceased. So unlike just sort of reviewing death certificates or trying to find out this information in other routes, these were the results of lengthy phone calls with people. I just want to say, when I say qualitative data, I'm talking about extremely detailed qualitative data, meaning I'm on the phone with the last girlfriend or boyfriend who's telling me things about the medical student that they don't want the parents to know. I feel like I have sometimes more information about the suicide than the family does. Okay, and so it's just an interesting position to be in. This chart represents 816 physicians in the largest specialties, and approximately, like 80% of them are US based and 20% are international, and many of those from India, I have to say, because India, in my opinion, is very advanced or more transparent in their thinking about suicide. Maybe it's a comfort level with death that we just don't have because we're kind of too prude in the US. But, the point is they have an abetment to suicide law in India, which creates a certain level of accountability and transparency that we just don't have in the US. It's also in Pakistan, I think, this abetment to suicide law. So anyway, about 20% of these are medical students and 80% physicians, I want to mention as well. This is a much more significant slide because it really details the the cases by active physicians per largest specialty. So from this, you're able to ascertain this is what I wanted to know. This was just my own personal interest, like which specialty has highest suicide rate? And it's definitely anesthesia. They are dying by suicide, number one, almost twice the rate of next lowest, number two, surgeons, general surgery, and then emergency medicine. Before I did this research, I thought psychiatry had the highest suicide rate, maybe because my mom's a mentally ill psychiatrist. But anyway, actually, they're number four. Sometimes, depending on when I have crunched the data, they'll switch with OBGYN. You can see it's kind of close there. But in general, top three are always anesthesia, general surgery, emergency medicine. I want to talk about two very simple solutions, just so I don't leave everyone floundering in despair. Number one, we need to remove these mental health questions from every single application having to do with medical licensing, hospital staff privileges, insurance credentialing. It is just ridiculous. I'll just read this. This is what happens to people by checking the yes box. Have you ever been treated for depression? I was required to sign a 5-year consent agreement with stringent quarterly regimen. Each quarter, the following had to be submitted to the state board: evaluation letters from multiple colleagues to affirm my fitness for practice and appropriate interactions with staff and patients, scheduled meetings with an assigned psychiatrist for validation of my fitness for practice, and a meeting with the board subcommittee, all completed prior to that month's board, all because I did not hide having been depressed and still am taking an antidepressant. I've always wondered what would have happened if I just lied and said I'd never been depressed. This is just ridiculous. This is punishing people, okay? I want to share, in case you are interested, please look up this article. This is my only peer-reviewed article of pain in the butt to produce a peer review journal. I don't know if you've ever tried that. It's a lot of work. But anyway, I spent all summer with an intern working on this state by state by state, analyzing the mental health questions throughout the US. If you are ever curious which state is more progressive than others on their mental health questions, I would highly recommend that you just go Google that title of the article and read, at least find out where your state is, where it ranks. And just two more quick examples of removing these mental health questions, the impact of having them there. This is a friend of mine told me after reading an article about one woman's journey through hell after being honest on those medical board application questions. I sought care an hour away, drove, like hundreds of miles in another direction to nervously fill prescriptions for antidepressants. I required these meds to stop thinking of suicide all day, every day, and my suicidal thoughts were 100% work-related. And finally, I was definitely subjected to discrimination. It comes up every time I apply for a new job, license, or malpractice. All I had was run-of-the-mill outpatient managed depression. I probably should have just chosen to lie about it, like 95% of applicants must, but I didn't. Almost 20 years later, it's still hanging over my head. So the very simple solution is we need to replace any sort of invasive non-ADA. These are non-compliant with Americans with Disabilities Act, these questions. We need to replace them with this simple question, actually. Do you currently have a condition that impairs your ability to practice medicine safely? So I would suggest that all of you go to your hospital staff office, look up the credentialing application at your hospital. If you find any mental health questions, please have them removed. You can do that quite easily. It's a little longer process with the medical board, but I just think we need to start addressing this so that people feel safe to get mental health care. The other thing, very simple, that can be done, thank you notes. I know it sounds kind of touchy-feely, but let me just tell you, so many doctors have told me that it was a thank you note from a patient or a colleague that saved them from suicide. Just an example. I keep every note from my patients. It has definitely prevented my suicide. There are days I want to give up, but I see the letters, the thank you cards, the art, knitting, jewelry from patients, and I keep going. I'm reminded that life is about more than my pain and suffering. Okay. And I also want to say this isn't just something I'm pulling out of a hat. This is randomized controlled trials with veterans have showed that writing caring letters was the only intervention that actually had a positive impact on preventing suicide among veterans. And so this is actually a text message, 51 words that saved an ENT surgeon's life. Hey, I'm sorry about your patient. That sucks. I'm very thankful that we have you as an excellent otolaryngologist to learn from. You take care of so many patients and do a marvelous job educating us how to do it safely, skillfully, compassionately well. Thank you for that. This came from a resident, saved his attending from suicide. So I just really want to, the bottom line, what I want to encourage you to do is please save all your thank you notes in a box that you can access. Might be better than Prozac, Lexapro, who knows, to have this box sitting around. And then also be very generous with your appreciation for your peers. And then maybe I think in every clinic, they should have a thank you box at the front where patients who are in the waiting room or when they leave can leave thank you notes for the doctors. Instead of just all these online reviews, there's something to be said for having the physical, written, and I'm not just saying verbal appreciation. Doctors are the type of people, we have a big moat around us. We don't really let in appreciation that easily. I think we need to read it over and over again and have the card in our hand. Okay. And just to give you a few free resources at the end, I have 10 years of free resources on my website. Here are 2 free books, a free audiobook, free ebook. You can just get them simply by going to idealmedicalcare.org, click on books. And also, just final slide, I want to say this is the International Medical Student and Physician Suicide Helpline. What happens is people write me and then I call them back, usually within a few minutes to an hour or so, and some people say after writing to me, they thank me and they say, don't worry about calling. I feel so much better that I've been able to share this for the first time to a peer. So there is the impact of writing how you feel and knowing that it's received by somebody who really cares. So that would summarize everything I have to say, other than I just want to close by mentioning in 2 hours after this is over, because I need to leave in about 40 minutes, I have another session. You're all welcome to join a free Zoom session if you want to continue talking about this, because I'm not able to probably stay for the full Q&A. And I guess I will just put that in the chat, the link, if you want to continue the conversation. Thank you so much for allowing me to share this.
Thank you so much, Dr. Wibble. Before I introduce our next esteemed speaker, I just wanted to say that we do have a QR code for a small survey we're going to do after the talk for anybody who's interested in filling out a short insight about how they feel about the burnout. I will put that link in the description box, and Dr. Mansouri will introduce our next speaker.
Thank you so much, Dr. Wibble, for the eloquent presentation. And thank you, Ammu, for allowing me to introduce my most favorite person, Dr. Qayyum, who's my program director. And she is the training director at Boston Children's Hospital, Harvard Medical School for the Child and Adolescent Psychiatry Fellowship Program. She's also a lieutenant colonel in the United States Army Reserves, and she holds faculty appointments at both Yale and Harvard. She has particular interest in areas of medical education, supervision, and mentorship, the impact of patient suicide on psychiatrists, acute psychiatry, and psycho-onc and palliative care. Welcome, Dr. Q.
Thank you so much. And thank you so much for having me. And it was a lovely talk, Dr. Wibble. Lovely to virtually meet you. One thing I just wanted to say, since it's fresh in my mind, as a training director and as a clinical educator in psychiatry, and particularly right now as a child psychiatrist in the midst of a mental health crisis for kids, thank you notes will not come through. We have very angry parents and people who are very unhappy with the state of affairs right now. Something I have to always prepare my fellows for is in psychiatry, sometimes our patients are so impaired and ill that they're not able to. So find your roses amongst your thorns. For me, I remember one of the things that kept me afloat was reading my evaluations from my students. In a particularly rough day, saying back that this medical student who rotated through our service had a wonderful time and said I was a good educator, and fine, that will save me today. But that said, I absolutely agree with what was discussed by Dr. Wibble and also in the video, because there's definitely this sense of silence that enshrouds physician suffering. And whenever there is a difficult outcome, an adverse event, we tend to compartmentalize and move on because the system is not set up to help us have time to reflect or process or access support. We don't always have a culture that rewards help-seeking behavior or supports it. And to Dr. Whipple's point that a lot of things about burnout and physician suffering is the solutions posed are very individual, but people are suffering because of the way the system is set up, and therefore the solution needs to be much more global systematic change than in addition to empowering our physicians and providing them support. So my work basically came from the impact of patient suicide, and I've been the medical director of child and adolescent and young adult inpatient psychiatry units, and I've had a few patients who've died by suicide. And when I was looking at how do I support my trainees when their patient dies by suicide, I couldn't find anything much. And having worked in pediatrics and adult psycho-oncology and palliative care, I talked to my hem-onc colleagues and said, do you have a curriculum of how do we support our medical students and trainees if their patient dies? And they have nothing. And I was thinking in psychiatry, we have patient suicide. Patients have been dying by suicide. People around us have been dying by suicide since ages, but we don't have anything formal. And so that was sort of the area of my work, because one of the things that triggered it was I had a medical student who had been following one of my metastatic a kid with metastatic osteosarcoma who was 12 for 3 years, since he was a first-year medical student till the time that patient died when he was 15. And I was looking for that medical student saying, he's come to every single appointment. He's gone to this kid's home. He's gone to this kid's school. Have we checked in on this medical student? And the answer was, well, if they are struggling, they'll reach out to us. And there was nothing in place to support a medical student in terms of patient loss. And what's different about patient suicide, having worked in both domains, is that I have a whole list of patients. And when I looked at them while I was working in the cancer clinic, 2/3 of them had already died by the time I was transitioning. And no one had ever come to me and said that you're responsible for this patient's death. It was cancer that killed them. But when a patient died by suicide, there's this suddenness, this unexpectedness that comes with it, that when I called the family with my social worker to say, we're sorry, we heard about the 16-year-old who died, the first thing the family said to me is, they don't want to talk to you right now. It was an uncle who answered, we'll get back to you with our lawyer. So knowing that we need to support each other and our trainees in particular, when there is a high risk period in particular, where there is an adverse outcome, or for physicians knowing if they're struggling with patient complaints, any performance issues, these are things we don't normally talk about, but it is important to keep a hand on the pulse for everyone if they're going to have a difficult situation, because it is very much kept under wraps. It brings a lot of shame and humiliation to think about, hey, I failed that exam, versus there's a disciplinary action, or there's a patient complaint, or I'm at risk of getting sued. That the whole legality of it also precludes a lot of people seeking help, because, hey, there's a malpractice issue, or there's a negligence claim being made, so you can't talk to anybody about it. And that makes things very, very difficult for people to access care and support. But one thing I'd say about that part in particular is, you can't maybe discuss the details of a case or the issue, but that does not mean that you cannot seek support for how you feel about it, and discuss your emotional reaction to the difficulty. So I just wanted to make that clear, because that's a question that always comes up, is the legal department will always say, or risk management is like, you can't talk about this to anybody. And then I really would put a word in for supporting our trainees, and making sure that there is some sort of system in place that takes the onus of giving them mental health support, time to recover. if there is a patient outcome, regardless of whatever the specialty is, or it's been a difficult time, that we create the space as educators so that they can process and reflect. Very recently, we've had a very difficult patient on our service who's been stuck for a year and getting in restraints all the time. And it's been very traumatic for all the trainees that have been involved in this patient's care. And our trainees were absolutely right, is can we all come together and talk about how difficult this is and how helpless and incompetent and ineffective it makes all of us feel. Just putting that in for the faculty, not that we're not struggling or have enough on our plates, but it's important to open that door of communication and model that openness of we're willing to talk about difficult things. We're willing to share with you how difficult it is for us. And we're human just like you, but at least these are things that work for me, or these are some difficult experiences that I've had that might model or give you some sort of scaffolding in which you can also process your own experience. And I'll end with that, so we have some time for questions.
Thank you very much, Dr. Q, for that eloquent talk. I'd like to invite Dr. Priyanka Kohli to introduce our next speaker.
Thank you. That was very beautifully said. Thank you for sharing that. I'm going to introduce the last speaker, Dr. Ami Bakshi. She's a board-certified psychiatrist practicing in New York City for 10 years. She's the director of ambulatory psychiatry at Lenox Hill Hospital and oversees ambulatory telepsychiatry for Northwell Health. As the director of medical education, she also enjoys training medical students and residents alike, and she is also the past president of the AAPI YPS, or Young Physicians section, and she's currently on the AAPI Liaison Committee.
Thank you, Priyanka. Thank you for having me today. It's so exciting to be following two wonderful speakers, so thank you for that. One of the things that we talk about a lot, but we don't do anything about, is the stigma against the mental health treatment. We've had so many incredible major advancements in science and medicine over the past several decades. But one thing we haven't had too much improvement with is the stigma against mental health. We've seen over the course of the last couple of years, we see more celebrities, we see more professionals speaking about their personal struggles with mental health on social media platforms, etc. But the disparity still exists in the societal stigma amongst generations and amongst different cultures, and specifically amongst the South Asians. So I ran an inpatient unit for many years, and I saw many on the Upper East Side of Manhattan. So I saw many physicians, but never the same amount of South Asian physicians as would be proportionate to the number of South Asian physicians that we'd see on the Upper East Side of Manhattan. I didn't see that, but I got numerous phone calls. I have this family member, I have, a colleague, and including physicians, right? We hear about the burnout, but nobody wants to talk about it in public. You get the private phone calls. Nobody wants to get the treatment. No, I don't want to come into the hospital. No, I don't want to come in for therapy. No, I don't need medication. I'm fine. I can go see my patients. I just wanted to tell you I have a little bit of anxiety. I'm fine. Oh, I'm getting depressed. My mom's a doctor. She's really depressed. She doesn't leave her house. She doesn't want to take her medicine. Well, why can't she come in for treatment? What will people say? Right? That is the biggest concern. What will people say? Not just the external world, within the family. What will my parents think? And this applies to medical students as well. Medical students, residents, they struggle because it's not just, even if their program does offer EAP services and does offer resident mental health services, they still, fear what their parents will think. Will their families think that they're too weak to handle medical school or residency, why we did it when we were, in your generation. Why can't you? I see Dr. Kohli laughing but I really hope he doesn't say that to Priyanka. Like, it's not something that they're used to because they did manage it. The generation before us did go through it. But does that mean that we have to pass that same trauma on to the next generation? I'm not so sure about that. And we have seen a significant, increase in communication about it. There is, slowly over time, we see a decrease in the stigma, but there's still a significant amount of progress that we need to make within our South Asian community. We still need to, encourage the younger generation to talk about these mental health issues, seek resources that they weren't offered to them, perhaps. It's unfortunate. I wish we could go to each and every one of the residents or medical students or physicians even and approach them with additional resources. There's ample resources out there, but not everybody seeks them out. All we have to do is we need to encourage them. We need to acknowledge that some of this is normal, right? It's okay to feel burdened and it's okay to talk about it. It's okay to not worry that you'll be represented as a weak character or if you're looking for an excuse to complain. The number one way to have people feel that way is to educate people about mental illness, to educate people about that stigma. Because the more we talk about it, the more we will hear conversations about how we're not weak because we can't complete something. If you can't complete a shift after your patient just committed suicide, that's okay. We'll get you coverage. And that's what trainees need to hear. That's what attendings need to hear, right? This isn't just about, all right, let's finish the shift. All right, I'm here until noon. I can get through this shift and then I can go home and figure it out. No, it's okay. If you had a significant loss, it's okay to take a break. It's okay to send somebody home. It's okay to look for alternative coverage. That's okay. And that is not something that we're taught in training. That is not something that we even do with our colleagues. How often do attendings even say that to their peers? And that's something that we need to really start normalizing. It's okay to get help. It's okay to take a break. It's okay to not value productivity over our well-being. And that's something that I'm really hoping that today, after combining all of these talks that you're hearing, that it's okay to normalize, mental illness, but it's also okay to normalize, it's not okay to normalize burnout, but it's okay to talk about it. It's okay to talk about how you're feeling. It's okay to take a break. And if nothing else, that's what I hope that everybody from this talk can take today. That's all I have.
Wonderful. Thank you so much, Ami, for that talk, and all the three speakers. Thank you so much for your time and enlightening us with those points. We would love to take questions right now. I think I'll take the first one, and then the other moderators will be asking the next. So Kinjal Salangi has asked, what do speakers think about the area that the top 3 factors affecting mental health crisis among medical students, trainees, and attendings, leading to the point of breakdown?
Well, I'm happy to share. I think it's a lack of labor laws that protect us like anyone else is protected in the country. In the US, just a quick example, there are state laws for a number of hours you can work. And I went and interviewed a manager at PetSmart about the dog groomers, how long they're allowed to work, 8-hour shifts, 2 breaks, and a paid lunch. Same thing with Starbucks. I asked them, oh, really? They can never work more than 8 hours? And she said, well, around Christmas, maybe 10 hours. Everyone wants their poodles to look under the tree and all that jazz. So I said, but why not more than 10 hours? She said, because we find find that the pets will die during the grooming process. They don't pick up the subtle changes in respiratory rate, the panic in the cats and dogs. And I'm like, oh, to me, I'm like, well, what does that mean for ICU? Probably not picking up subtle changes in patients. If you're, just let's face the facts. We are left in a very dangerous, precarious situation with no labor law protection if we're working more than we can physiologically work without being the equivalent of drunk. Our psychomotor retardation beyond 17-hour shifts is that of like having a DUI. Why would you be in ICU? So that, I think, is number one. No protection, basically human rights violations is what I would say, between sleep deprivation, lack of access, food, water, family. There was a psychiatry intern who told me that during this first 6 months of her psychiatry internship, she only saw her infant daughter during 6 waking hours of her life. So I'm going to call that a violation of human rights that also will extend to, let's just say, maternal deprivation in the next generation. So I'm never really asking for special treatment for doctors. I just feel like we deserve the same labor law protection of everyone else in the country: pilots, truck drivers, baristas, dog groomers. And I'll stop there.
I'll add that 30 years ago, 40 years ago, 50 years ago, there was only so much medicine to learn. There's so much more in the same amount of time. And we don't account for that when we're, going through residency. There's so much more people feel obligated to learn. You want to be the best of the best because that's what you've been doing your entire life. You've gone to medical school by being the best of the best. And so in order to stay there, you need to study a lot. You need to get all that clinical experience, but you only have so many hours in the day. So you're going to have to sacrifice something. What do you sacrifice? You end up sacrificing the easy things: your family, your health, right? The things that nobody's fighting and pushing for. But like Dr. Wardell said, if we had labor laws, if we had stricter guidances on how to minimize these extended hours, perhaps maybe put in a little bit of extra support at the end of those hours, even, that could go a long way.
If I may, I want to applaud all the speakers for their eloquent presentations, and I have a lot of questions and some observations as well. Starting with Dr. Weibel, I think the numbers are a little bit different now than before, even though 300 to 400 physicians dying by suicide was often quoted number. More realistic data recently saying about 119 physicians are dying by suicide. That is, I don't know what you take on that. Of course, a lot of these numbers are underreported as well, like you mentioned, from your own personal qualitative data. Second thing is, according to more recent data, the female physician suicide is still high compared to general population, whereas the male suicide rate physician is a little bit lower than general population rate. Another thing we often quote is physicians are the highest suicide among all the professions. That seems to contradict some data that other professions equally have it, and we are kind of in the middle of it. So still not to be kind of minimized. My analogy is a physician dying by suicide is like a farmer dying of starvation, or a race car driver dying of a car accident. It should not happen. We should be the first one to be able to take care of ourselves. And as you all know, to replace a physician, it takes about $100,000 to $200,000, and many physicians are dropping out of profession due to this burnout, and we're losing a lot. And it estimated to be 4.6 billion are spent to replace this physician. It's almost losing a class of medical students every year. So we have a big task and challenge ahead of us. We need to resourcefully tackle that. Coming to Dr. Qayyum's presentation about physician resident suicide, I think there is some evidence that faculties are getting a little bit better in handling the residents' feelings as well as educational needs. From what I hear from anecdotally, some of the physician faculty members are not trained well or equipped well or even motivated to kind of give immediate feedback that is helpful to the physician residents. I think we need to spend more resources from the institution-wise to train the faculty. I don't think our faculty is well-trained at this point. Resources are not provided to them. They're expected to volunteer their time. That's not going to work. And because medical colleges are charging enormous amount of tuition, so there's no reason for them to be depriving the students and residents of basic needs. I know it's a human rights violation, what we talk about. I think we need to start from our own backyard to clean up a lot of problems that we are creating for ourselves. Third thing, Amy, you're right on the money. You spoke so well about stigma, especially these days. I've been talking to a lot of diaspora physicians, not physician, non-physician communities, social organizations, community organizations about exactly the same issue, especially South Asians, especially immigrants have a higher rate of mental health problems, twice the rate of their first generation immigrants. So, and that is partly us, our own culture. We feel ashamed to seek help. We feel it's a shame and a burden and a kind of a mark on our family. We don't seek help, and we discourage seeking help behaviors. And we feel as a parent, we fail if our child has a problem. And I can vouch for myself. I never put any pressure on my children. She happened to follow me. I didn't ask her. Priyanka chose her profession on her own, which I'm proud that I'm happy for that, because we need good physicians as psychiatrists. Third thing is, there are so many factors I just want to mention because you don't want to lose my train of thought. And yeah, you talked about mental health stigma. There is one more thing I'm talking about in my here as the physician, as a psychiatrist and the AAPI president. Mental health stigma, mental health awareness, suicide, burnout, physician. Actually, last journal we published was about physician wellness, and some of you have written articles in that as well. And it's well composed, and I would like everybody to take a look at it when you get a chance. It's on our website as well. I think this is the book journal we published. Thank you. And anything else I wanted to say? Those are the main points I wanted to make. So we need to make our residents and students comfortable seeking help, and we need to put our resources where where the money is, the word is. So we had to start in our own backyard first, and student needs to be encouraged to seek. I know there's a lot being done in the last few years. For example, 26 states have changed their questions and licensing criteria about, like Dr. Weibel said, are you currently impaired by any mental health or substance abuse or any impairment? I think they're globalizing rather than they're not asking it as a mental health question. So I think that gives us a room to interpret and room to answer honestly, but in a way that doesn't impair us, because seeking help is very difficult if you have to report it to every quarter, every 6 months. So that should be discouraged. We all should take lead on that to encourage to be kind of removed. And so the same thing with hospitals and organizations and everything. For example, we don't treat fraudulent physicians as severely as mentally ill physicians. So we need to kind of change our priorities. So I'll stop here. I think I've taken more time than I intended to. Thank you.
Thank you very much, Dr. Kohli. So those are great points, and I appreciate your reflections and your comments. So we all understand that there is a big need of addressing the mental health concerns. As Dr. Ami Bakshi says, it's okay to accept it, and both all the speakers have given resources regarding that. I'd like to take next question, Zishan. You can.
Can I just respond to Dr. Kohli briefly, really quickly?
Yeah.
He said something really important. He said, the change has to happen in our backyard. It has to happen at home. We have to be the initiators of this change. Everybody on this call, if you're a trainee, if you're a medical student, be that person who reaches out. If you're of South Asian descent and are afraid of getting, going to access help because of what your family may think, it's okay. Talk to somebody at work. Find a mentor who you can feel comfortable speaking with about when you're getting exhausted, when you're tired, when you're burnt out. Ask for help, ask for advice. And if you're an attending, if you're already an established physician, seek out that student, seek out that resident.
Yeah.
It doesn't be somebody who you think is failing or somebody who you think is about to commit suicide. Nobody's expecting you to be able to seek those people out. But just find a student, find a resident who you think you can just talk to and be a mentor for and provide support for. That maybe, you could make a change by just impacting one person, right? That's all you need to do.
Yeah,
And we
I
can
mean,
start-
you said it right. Actually, I wanted to say this. It's okay to be not okay. I think
yes,
that's what we need to propagate. And nobody is okay. Everybody has the good days and bad days. It's okay to be not okay is my slogan and my tagline for this year. And another thing is another best. I think Dr. Weibel mentioned about thank you notes. I think self-compassion has proven to be the most effective way of dealing with our own self-criticism, self-punishment. I think Dr. Weibel also mentioned as a group, we choose this profession because being very conscientious, very socially oriented, very altruistic. That has the like a functional aspect of it. The dysfunctional aspect is we kind of put ourselves behind everybody in the back of the line. We don't take care of ourselves. We feel it's selfish to take care of ourselves. I think we need to practice self-compassion. We need to practice gratitude. I think I wrote about this in my articles. And gratitude for ourselves, for our ability to do what we do, and also express gratitude to other people who are able to do other things, even thank you notes. I think gratitude journaling and self-compassion have proven to be the best self-help practices we need to kind of use and kind of propagate. I've been doing that in my talks and my articles. So please, every one of you, practice self-compassion. And some of you are practicing a lot of good practices, like Jaswant is going out and riding his bike, and Priyanka is going out hiking and all those things. Please continue to do all wellness practices, gratitude, connecting with people, kind of all those things. Connecting with people is so important. Any human connection is very protective. Loss of human connection and that kind of isolation is very destructive. So stay connected, stay well, continue to practice what we need to practice to help our patients. Because burnout causes a lot of damage to healthcare. And also, burnout physicians are more biased. They have implicit bias. We treat our patients very negatively, especially in minority groups. So not only it's hurting us, it's going to hurt your patient. So if you don't take care of yourself, nobody's going to do it, and it's going to hurt everybody.
One very quick point, and thank you so much. The self-compassion is absent from many of us when sometimes we become our worst abusers. We adopt these self-berating, we don't forgive ourselves for minor mistakes in which no patient is harmed. I have people in my support groups who come there suicidal. No patient was harmed from some minor mistake that only they know about. But the one thing, just a caveat about, are we highest profession for suicide? How many per year? I don't think anybody really knows. It's impossible to know the data. However, what I do know for sure is that unlike farmers, race car drivers, and all that, we are able to hide the suicides amongst our colleagues because we're completing the death certificates, and farmers and race car drivers are certainly not doing that. And I also see evidence that they will sometimes call accidental overdose for physician death, which I think is complete crap. I'm sorry for the language there, but maybe it's not 100% intentional, but it's certainly not unintentional, 100% unintentional, like a toddler crawling on the bathroom floor with pink Tylenol pills. If you are an anesthesiologist and you dose this drug all the time, or family doc, and you dose this drug all the time, you are not 100% unintentionally dying of an overdose from a drug that you dose all the time. So I find there was an ACGME study in which they came up with number one highest cause of death among residents. I think they said females was neoplasm, male was suicide. But when you really break it down, out of the 324 cases, I believe it was, they excluded 28 as accidental overdoses. Accidental, and I'm like, you are not accidentally overdosing as a resident. So I think we have this sort of interesting, willful, cover up, sweep it under the rug attitude, because it is hard to face the truth that we could be the number one, for suicide among professions if we stopped hiding. For cultural, religious, and professional reasons, we are hiding the truth in a way that farmers and race car drivers just simply can't. Anyway, just wanted to add that.
Thank you so much, Dr.
We need to start from our own backyard and cleaning up everything. Yeah, agree. Totally agree.
And one small point to add to all of this is we also need to speak up when parents, especially South Asian parents, force our kids to take up medicine without the interest in it and without the potential for it, and they really want to make them doctors, no matter what. When these conversations happen in front of you, speak up. Speak up on why that should not happen. Speak up on why the child needs to follow their own dreams and not follow their parents' dreams. I think that is an important fact that our South Asian populations do not do well, at least from what I have seen in my vicinity.
Yeah, I agree. I echo that. We tend to live vicariously through our children's success, which is kind of pathological, toxic. And I kind of claim some pride that I did not force any of my children. One of them is physician, one of them is not. So I let them live their own lives and make their own choices. I trust them, I respect them. I don't have any, actually they're smarter than me and they give me a lot of help in making me a better person.
Oh my gosh, Zishan, I hope I'm saying your name right, but I just want to say two things. Though, if you were to watch the full length of this film, 86 minutes, the star of the film is a deceased medical student who died just weeks before graduation named Kevin Deal. The filmmaker went through some home videos of that child and parents, and at the very beginning of the lengthier version of the film, you see the father holding the infant in his hand saying, Stanford Medical School, you want to go to medical school? You know, so that was like, wow. I mean, just like stabbed me in the heart. And then also there is a woman who's in the film, I will not out her, but she's activist on physician suicide. And the minute her infant daughter was born, she has on Instagram, #future-doctor, dressed like a doctor. And so I think even if you want to be aware of this and prevent physician suicide, there's some sort of weird need that we have to just dress our little babies up just like ourselves and put them all over social media with #future-doctor. I don't know if you have some delicate way of maybe approaching these people. I didn't approach her and say, excuse me, this might not be a good idea. But I mean, I think this sort of just subtly seeks into our children's persona and they want to do right by us because let's just face it, their survival's linked to us being happy with them and loving them. So it's terrifying for them to think that they might lose our love, right? So I don't know how to approach these social media posts, but somebody needs to say something.
One thought I had was based on what Zishan was saying is in our South Asian communities, the sentence of what will people say has killed so many hopes and dreams all by itself. But unfortunately, it's come to a point where it's killing people now. And that's where I think we have to step away from what will people say.
Absolutely, I think that's very true. So the next question, we'll get to it. How do medical students cope with two kinds of factors? One, that is not in their control, and two, some things that are in their control. And vice versa, from the viewpoint of the program, like how should they ask for help without like outing themselves? Because a lot of these anonymous things, are they really anonymous? That's a question like every single person who approaches me asks, like what actually is the level of anonymity when you go for a therapy session that your program recommends, or all these online therapy things that happen in an anonymous fashion? What is the level of anonymity there, and how comfortable should a physician be in terms of like losing their license when they do it? So I think we can start with Dr. Q first and then go on to Dr. Bakshi and then Dr. Vibal.
Sure.
Oh, I just have to leave right now. I want to say, because I have another thing right now, but I left a link if anyone wants to have continued conversation with me. And I really want to thank you all for inviting me. I'm honored to have been part of this esteemed group of people. So thank you so much.
I
And,
just
Thank
wanted
you.
to say, Dr. Vibal, thank you so much. We'll be sending an appreciation certificate soon. And thank you for attending.
Thanks,
Thank
Dr. Weibel.
Thank you,
Thank
Dr.
I
Vibal.
hope I got your name right.
Oh yeah, you did. It's Weibel, like Bible, you know. Okay, bye.
So in terms of confidentiality of seeking support, I can say, depending on the institution, many programs have contracted with outside providers to provide that level of anonymity. So people can reach out to someone outside their institution as trainees or medical students, and it's not within the purview of the institution. I think those work really well. We tend to do that for our program because we actually have an Office of Clinician Support at Boston Children's, which is for all physicians and clinicians and nurses, and unit debriefs when there's a very difficult, challenging case, or there's a really bad death on a particular unit, or the ICUs had like 5 deaths in a week to support the staff. But Because it is through psychiatry, some of our psychiatry trainees don't feel comfortable coming to our Office of Clinician Support. So we have a reciprocal relationship with one of our fellow institutions. And I can tell you, I never hear anything back. I don't know who went. I don't know who sought support. Sometimes people might come to me directly and say, I'm relocating from my medical school. I'm starting residency. I used to be in therapy. Can you help me connect? Or also, one of the things I have to do as a program director is make sure someone who's in therapy has protected time if it's within the workday, and say, yes, I will give you that time. And I will make sure that your clinic does not schedule a patient during that time. But you have to tell me, I can leave it anonymous with other people to make sure they don't know why I am giving you that one block hour for whatever purpose. That is not for people to know. But sometimes you have to find who are the right people you can trust, and what you can share with the right people who need to know. And I think trust is a two-way street. We hope that your faculty and your training directors earn your trust to be able to allow them to support you and help you. But I can say really that most of it, unless I am recommending someone go for support because they're struggling, and formally asking for some help and recommendations, those things don't come back to me. And even if I've recommended someone to seek mental health help, the only thing that will come back to me as a training director is recommendations to support the trainee. What they talked about, what the diagnosis is, what the problem is, I won't know. The only thing I will get in writing is something that I can then work with GME to say, or undergraduate medical education to say, I need to support this trainee. These are the recommendations, and now I have grounds to be able to provide them.
If I may, can I ask some of the participants to make some comment? I think we need to hear from you as much as you're hearing from us, because you are the ones in the trenches. So it helps us to kind of formulate our plans and ideas as well, if I may say so.
Sure, Dr. Gul, if anyone wants to speak, can you raise your hand and we can unmute you? Or just comment in the chat and we can unmute you.
I see Jaswant is
yeah, I'm unmuting him. Yeah. Go ahead, Jaswant.
Hi, everyone. I'm Jaswant. Nice to hear from so many different people and thought leaders as it pertains to physician burnout and suicide. Going through medical school in San Antonio, we had this screening at my medical school, so it was really impactful to have that exposure at that stage in my training, and I think it's helped us develop an appreciation kind of moving forward as far as prioritizing reflection and self-compassion, as was mentioned here in our conversations. But I think as residents, we kind of lose sight of just in the daily humdrum of going to work and then going home. I don't know that it's as prioritized as it was back when we were medical students. So outside of resident groups, having mentors like Big Little programs, etc., what are other ways that you've seen at your programs or where you've trained that residents can kind of tackle burnout and promote wellness?
My reading is having a buddy system like VA has a buddy system, supposed to be the most protective. And another study showed that of all the interventions, the pass-fail grading of USMLE has the best outcomes for physician burnout reduction or student burnout. So there are some of the things. All the other things are not as effective, but my reading is those two are very helpful, if I may.
Go ahead, Priyanka.
Well, I was going to say, I noticed that Dr. Weibel mentioned the peer-to-peer programs in the chat, which I'm my program's residency wellness chair. And so this is definitely something that I think about often. And I noticed when that was put up in our call room, a little advertisement for this peer-to-peer, support group. My co-residents kind of like laughed at it and scorned at it because it's like it puts more work on residents who already are overworked and have very little time to do things. Or it's like wellness modules. They just kind of add to our already very full plate. So on that same note, like, are there things that don't necessarily add to the burden of residency that can actually make us feel better?
That's such a good point. Just last week, I had to go to a wellness seminar for trauma and resilience training, 5 p.m. to 7 p.m. on a weeknight when I could have been doing so many other things that could have actually made me feel better. But instead, like you said, we added to our plates. One of the things that people feel like they need to go and spend hours doing these types of things to feel better. It can be something as simple as taking a 10-minute walk. It can be as simple as picking up the phone and taking 10 minutes to yourself to call a loved one just to chat. Sometimes that's all you need, right? It doesn't have to be a 2-hour seminar. It doesn't have to be hours and hours of modules or whatever it might be. One thing just was mentioned earlier, his medical school had training on this, but residency didn't. And I am so hopeful that I'm seeing so many more med schools provide this additional level of education about wellness and mental health for trainees themselves, that I'm so hopeful in the next 8 to 10 years, we're going to see a significant change in the mentality, just simply based on people having learned this in med school. But that's not enough, right? We're hearing it, like we need more in graduate medical training programs as well. And so that's where I think if we can continue talking about this, we can keep bringing it up. This is where I would say, talk to your program director about these requirements. And it pulls at my heartstrings. I hate hearing that people don't feel comfortable because they're worried about the anonymity. Like, that is the worst. No, it absolutely should be completely HIPAA compliant, but also anonymous so your program directors don't hear about it. I hate that people don't want their program directors to know. There shouldn't be a stigma. If people have a medical illness, you have high blood pressure, you might tell your program director. So why not tell them when you have depression? Of course, that stigma does exist, and that is why people don't want their program directors to know. But in the meantime, they should rest assured, and they can talk to their providers about it. At our program, we instituted a resident mental health clinic. So although my entire outpatient clinic is on an electronic medical record, any resident who's seen by our psychiatrists have a paper chart. They're all seen virtually, so you can't come in and see somebody in the waiting room. And this is pre-pandemic, so the virtual element was there even before that. So there's no element of you seeing somebody else. There's no element, and we have after hours available for them. So you can do this without telling your program director. It's fully covered, so there's no insurance. There's no reason to go through anybody. Your parents don't need to know. Your program doesn't need to know. You just need to call the office, and we'll make sure we see you. I don't know how many programs like they're out there, but you shouldn't be worried about seeking treatment because you're worried about the anonymity. Talk to somebody, confirm, if you need a little bit of extra confirmation, get it from the person you're seeking treatment from, but please seek the treatment, talk to somebody. I see a couple of hands raised.
Yeah, thank you. Such a valid point. So I'm going to unmute the first, we have 2 hands raised and 1 question in the chat box. I think iPhone Lena is the name I'm seeing. If you can speak up.
Hi.
Hi.
Hi, this is Dr. Lena Gupta. Thank you for all the lovely, great, informative presentations each one of you had. And I loved Dr. Bakshi's presentation, the way she hammered it. I wanted to raise a couple of points. I'm Dr. Lena Gupta. I'm the chair of the publication committee this year, and we had the theme as agreed with Dr. Kohli about having physician burnout, and we had a tremendous amount of response from all the authors and many physicians who reached out to us, which is really very good for their own wellness and for wellness of the organization as well. I recently also had a wellness retreat for women physicians. So I think, and what we realized having this retreat was many of us, especially women physicians, we we just try to hammer ourselves, and we try to do, we could be a super mom and be a tiger mom and do this and do that and never take time out. And each of these women physicians who were with me in the retreat, they were so happy. They said, oh my gosh, we would want to have more and more of these retreats. So I think, as Dr. Kohli said, self-compassion, take a little time for yourself. Be it whatever field, especially in the high risk fields like psychiatry, critical care, anesthesia, where you do get burned out. So I really appreciate this great conversation which we are initiating. I hope that this conversation goes on and goes on internationally, reaches out to in the Indian crowd as well. And we should try to definitely take the stigma out, because that stigma is still there. And definitely the credentialing forms which has that mental, that's an eye opener. Why should we have that? That's a great point. We should all go back to our hospitals and get that out. Thank you so much.
Thank you, Dr. Lina. I have one more, Dr. Solanki, and then we'll conclude. Kinjal, I think I've unmuted you. You can speak up. Do you have a question?
Yeah, while Kinjal is coming on board, we had some meetings with FSMB, which is a medical board organization. They are also promoting removing this questionnaire. Ami, you're one of the members of liaison committee. We're going to have a meeting with them soon again to hammer that point. So we'll keep working on different fronts. Thank you. Go ahead, Kinjal. Sorry about that.
Yes. Hi, everyone. My name is Kinjal Solanki. I'm the past AAPI MSRF president. I just wanted to share some strategies and tips from my personal experience. When I was going through residency, I was trained at a very busy internal medicine residency program in New York, in Queens, New York. And some of the things that helped me get through residency and fellowship as well include, number one is to have a good social support. That could include either if you're close to your parents, that you can talk to your parents every day, or not every, you don't have to talk to them every day, but whenever you need them. If you had a difficult patient at work, call your mom or your dad up and talk to them about it. Even if they're not in medicine, at least they will listen, and they will know what you're going through. And this will also bridge any gaps between children and parents. Luckily, I didn't have to do that, because honestly, I felt like my parents were away from me. So I found really good friends at work in my residency training programs that I could talk to about any problems that I've had, or if I was struggling with a patient, or if a patient of mine died and I felt like I needed to cry to somebody. And I had friends who I can call up who were going through the same things as me, especially in intern year. This is very important, because your intern year is going to be your most important year in terms of changes that you will be going through. It's a very steep curve, and not mentally, physically, psychologically, in all sense. So it's very important for you to seek out these avenues. So one is support for sure, spouse, parents, or friends. Second is to be involved in groups and communities. Some of you are involved with AAPI, so that what life is like on the other side. What life is like as a fellow. You talk to fellows, you talk to attendings, so there is a light at the end of the tunnel. So that's one way is obviously AAPI. Then I was involved in something called CIR, which is community of interns and residents. It's like a unionized group, and not every hospital has it, but there are good amount of hospitals involved with this group. And it feels like you're doing extra volunteer work in addition to everything that you have on your plate, to be a part of these organizations, but you also see that other people are in the same boat as you. So you can share your thoughts and your experiences with them. So, and the third thing I would really like to emphasize is get your priorities right. You won't be able to do everything while you're in residency. So, have 2 or 3 things: your work, your fitness, your hobby, like, and your sleep, right? Like sleep is, as we had mentioned today, sleep is very important. So have two or three things in addition to your work in your daily schedule, and try to maintain as disciplined of a life as possible, although that's hard to do because your schedule will change. Every 2 weeks you are going to be, you're working day shift, and 2 weeks later you're going to be on the night shift and in the ICU and all of that. But if you have your priorities straight, you should just be able to focus on those top 2-3 things, and you will get through it. So once you have developed that resilience, try to spread the word and try to be there for other people.
Thank you, Kinjo. Those are good insights. We do have a robust discussion happening in the chat box. I see that some of the questions has also already been answered. If anybody has any more questions, you can raise the hand, or we can unmute you and you can speak. While doing that, I just wanted to introduce a little bit about AAPI MSRF to you all. And then I know this discussion can be quite triggering. So if anybody wants to stay back and talk to us, we're more than happy to stay back and address any concerns you have. Just want to talk about MSRF. This is our current board. Not all the members are in our board in this. And this is a current program that we're doing. And we are doing a survey regarding assessing the burnout and wellness in our participants. So please scan the QR code and take a minute to fill out the survey. It'll greatly help us to get some insights. Just wanted to give a throwback of some of the events we did previously. We did have, starting with the residency application, fellowship application, we started with a strategy and timeline partnering with USMLE Sarathi. We are partnering more events, webinars regarding residency application and fellowship, including a program directors panel. We just concluded a South Asian cardiovascular health talk, which was very well attended, conducted by Albany Medical School. And some of our future events coming up are, we have a virtual international research symposium for students who are not in the United States but want to participate in it and unable to travel. And we do have an in-person research symposium and a conference happening in Vegas in February 17th to 19th. That's the Winter Medical Conference, and we are accepting abstracts for that as well. And we just had our wellness retreat 2 weeks ago. We also have an academic journal called JAPI, who are accepting public manuscripts for publication, and we do have awards for YPS MSRF members. I strongly encourage you to join us. We are on Instagram, Twitter, and Facebook, and we have our own website as well. Now, I'll just quickly go back to the discussion to see if there is anyone else has raised their hands.
If I can make a remark, I think there's a little bit of emphasis on personal wellness. I think there are 3 legs too that we need to work on. The institutional cultural change that we have to start from the organizational point of view. We have to break the system to make it better sometime. Second thing is chief wellness officers have to be there in every system to help facilitate our people needing the help and getting the help they need. Third thing is the personal resilience and personal wellness, which we discussed at length, but that's not going to answer the problem. There's only one small step, but the bigger picture is the system failure, systematic problem that we need to address. So all these good things that you're doing and we're doing for ourselves are good, but that's not going to completely, it's a Band-Aid, basically. We need to address the cancer, more toxic cancer that is in the system. Sorry for saying it so bluntly. Thank you.
Thank you, Dr. Kohli. So if there are no more questions, Zishan, have you answered all questions in the chat box? Just wanted to make sure before I conclude.
I think people have been answering questions even in the chat.
Thank you so much, Dr. Kayam, for answering some of the questions. I saw that you've been answering as well. And Ami, thank you for your time. And we'll be sending out a certificate of appreciation for this participation. We're also compiling all the mental health resources we can put in our for this community, and will be available in our website for anybody to access. And we thank all of you for your time, and we look forward to your participation in our future events. Thank you very much. Have a good day.
Bye. Thank you, everybody.
Thank you.